All right, guys, this is Dr. Holly Bryan coming at you again for another course. This year's going to be for Mod 3. We're going to be covering the foot and the ankle and some of the pathologies. Now, I left a lot of this stuff in here from my previous webinar we did. I think I did this back in 2014, and it's been included on a couple sales. There's just such great information in here. To be honest, I changed some of the things, but I was going through this and I'm like, man, this is really applicable for what we're talking about. So for some of those that have had this in the past, this is going to be a good refresher. There's a couple new things I've added. For you guys that haven't had this, I doubt you're going to find a lot of training on the foot and ankle like this. So get ready to take some notes and you get to see some stuff. So, and we got some gruesome images in there for you weak stomach minded people. So, and I'll give you a heads up as we approach on that. So anyways, let's go ahead and begin the course on the foot and ankle. Right off the bat, before we get into the anatomy of the foot, there's three main foot positions that you're going to see people coming into your clinic with. Your studio, your office, your massage room, you're going to see them coming in with. It's either the normal, which is right in the middle, and you can see the line. This is the posterior, the back of the leg. And the calcaneal tendon should line straight up and down with the heel. For the pronated, which is flat foot, you can see it actually curves in, and you'd be surprised how many of the population actually have this, especially when they run. And we're going to go through I'm going to show you some things on how to see if it's a compensatory or if it's actually a structural type thing that's been there for a while. There's a couple little tests that we can do. Then you also have the supinated, which is the high arch, the high foot. You're going to be rolling outward. And you're going to see how a lot of times the pronated can lead into bunions. And this here, the hallux bunion, which is the big toe bunion, this also can lead into the Taylor's bunion on the supinated. We'll get over there. And the term is for a pronated or flat foot is called pes planus. And on the high arch is called pes cavus. Pes meaning foot. Just like a cave, high arch, you form a cave, okay? So that's what that means for those. Those are the three foot positions we'll be talking about. 26 movable bones in the foot, and we are not going to go over each one of them. There is actually no way. We're just going to cover the big daddies. That's about it. So we got our heel bone, which is called the calcaneus, and it's the most posterior tarsal bone there is in the foot, okay? We have our rear foot, midfoot, and forefoot whenever you divide them up. And we're not going to get into too much details on the anatomy. I don't think that's as pertinent. You guys have studied enough anatomy, and if there's plenty of things if you wanted to memorize the bones. I'd rather get into the function of things, to be honest with you. But the key function of the calcaneus is to form a connection between the leg and the foot. This is like the saddle where the tibia and fibula come on down and they anchor on top of the calcaneus and the talus. The talus is like the main shock absorber. Okay. And let me see. It also has where the body weight. This is the transfer point. Couldn't think of the word transfer, so I was trying to read real quick as I was talking. This is the transfer of the weight onto the foot. It's also with physics. It's called the force, the normal force. This here is the rebound force that it will transfer up from on this, along with the gastroc and soleus for like a spring whenever you go in your gait cycle. Foot bones again. We have the tibia, the fibula, you got your calcaneus, the talus, then you got your cuneiforms, just like up in your wrist. You got your little cuboids and stuff. And then we have here the metatarsals and the phalanges, okay? Basically, phalanges of the foot have the same position as the hand. Basically, they're the toes, okay? So up in the hand, we got our metacarpals, and we got our phalanges and digits up here, okay? Metatarsals are number 1 through 5. Normally the first and the fifth are non-weight bearing bones. The 2 and 4 are not. Let me see. No, I said non-weight bearing. It's weight bearing. Excuse me. The first and the fifth are the weight bearing bones. 2 through 4 normally are not, unless you have some type of pathology going on. This here would be your first digit. This here would be like when we do our gait stance. The ideal stance is a heel strike, followed by a rollout with the weight on the fifth digit, the pinky toe, and then it transfers across the transverse arch to the big toe, and you get a toe off. And your gait is how it rolls around, is how it's supposed to be. But normally the ones in the middle don't do anything unless you have other pathological conditions, which we're going to talk about a little bit later. Metatarsalgia, hammer toe, claw toe. We're going to be hitting some of those, and you guys can see what those are about. The joints, basically the ankle mortise, lost my pointer here. The ankle mortise here is the talus, the tibia, and the fibula, the mortise joints, the three of them here. This here is like just like a mortise and pedestal. This forms like a cup right through here. You have your subtalar joint, inferior tibial fibular joint. Basically, the subtalar joint is the ankle found between the talus and calcaneus, and it's supination and pronation, inversion and eversion. Moving the foot in, moving it out, and rotating it upward for supination, and pointing it downward and outward for pronation. That is the subtalar joint's role in what it does. Okay. Plus, not to mention, when you're walking, it helps to have a joint that's mobile, because you're really absorbing, transferring the shock right up in here. And the main shock absorber this is the impact point. This is looking at it from the back. The impact point is going to be the calcaneus, your heel bone, but the shock absorber is going to be the talus. Okay, that's going to be, just think of this here's your tires, and this here's your shocks on your vehicle. That would be the easy way to do that. Okay. Again, some of the basic anatomy of it would be the three arches. The three arches enable us really to absorb the forces, the ground forces when we strike, and that's also what helps us propel and balance. You got your transverse arch, which is A to B. Okay, your anterior transverse arch, and you have your medial longitudinal arch, which should be B to C. I'm sorry, A to C. I'm reading it wrong here. The medial is on the medial side of the foot. This is the lateral side of the foot, so you get your lateral longitudinal. Together they form a triangle. And again, normal gait is heel strike. All the weight bearing goes roll out on up to the B, then it transversely crosses over to the big toe for toe off, is how it should be going. The transverse arch goes across the width of the foot. Normally the midfoot here goes right across, comprised of the cuneiforms, all three, the cuboid, and the base of the fifth metatarsal, okay, which is right over there. I don't have a good picture of that, or I'd show you. But remember, this here is the first, and over here is the fifth, okay, just to let you guys know. So the fifth metatarsal bone forms actually the lateral base of the transverse arch. Okay, and here's a shot of the longitudinal arch here too. This would be the medial longitudinal arch because it's on the medial side of the foot, and the lateral would be on the lateral side of the foot. So, I guess we're talking about these now. I forgot the slide was in here. The medial longitudinal arch is the highest and most important arch in the foot in many literature and in pathology, to be honest with you. It goes the entire length of the foot on the medial side, the inside part, comprised of the calcaneus, talus, navicular, cuneiforms, and the first three metatarsals. Okay, so this is the one that can cause flat foot. If it collapses, it can cause pressure on the toe joint, the big toe joint here, where you can start getting bunion formation, and there's a bunch of other things that can happen, and we're going to get into that. Then you have the lateral arch, which is the lateral longitudinal arch, is the one that's is more flatter, and it's on the outside of the foot, okay? Again, I'm not going to read all that to you, but you can read that. But this here is on the outside, where the medial inner arch is this one, and the outer arch is on the outside. And you guys have seen, normally people use this as a springboard, and you've seen people with completely flat feet or super high arches, where this arch here, the foot's just rolled out and it's flattened right out. So you put a lot of strain on the ligaments and tendons, and even on the bones down through here, the metatarsals and the cuboids, they all get jammed in, okay? So you can have some pathologies by not having proper arches, okay? Here's the gait cycle that we talked about. You're going to go heel strike, and this is the outside of the foot, not the inside, so this is the lateral side of the foot. So the normal gait, you'll have heel strike, then mid stance, you start to transition the body weight from the heel up to the outside of the foot. Then it goes across, and then when you propel, it's called the big toe. It's called toe off. The body weight will go from the outside, transfer over to the toe, and it's toe off. It kind of rolls out is what it does. From the outside to the inside, it rolls. That is the normal gait. Now, that's the gait with shoes, should I say. Recent discoveries are just with these, I don't know the term, but the glove shoes that have all 5 toes in them, and just going barefoot jogger. What they're finding out now is people with that is they have more of, when they do their impact, they don't just heel strike, they do midfoot strike, where they're almost a mid stance when they hit the ground instead of a total heel strike. They're still going up, and instead of just propelling off the big toe only, they're doing a fan and propelling off the first 2, sometimes 3, depending on the nature of the person's gait. So a little bit of changes with modern science that we're noticing. Okay, I know someone's going to ask, which is the better one? Well, I got to be honest with you. I've been jogging for a while, and with the shoes, and then we moved where we're near a beach, so I can go jogging in the mornings. Jogged with the tennis shoes, it does good, but if the ground is soft enough, meaning the tide is just right, I love to go barefoot jogging because I get better energy, better propulsion, and my joints don't hurt as much when I go barefoot. Now, it takes a while to get used to that. Just like if you read any articles about putting on those shoes with the fingers in them, the glove shoes, it takes a while to get used to those. Only wear them for a couple hours a day, then go back to your other ones until you adapt. Okay. But yeah, they say it's actually better to do that because it actually allows for the foot to move in and out, splay, and allow it to splay, spread out as it does. And it really strengthens the tendons and the ligaments. So you use your own judgment on those. Pes planus, flat foot, a condition, we talked about that, which is a pronated foot. When the medial arch is dropped, how do we know if it's a structural thing or if it's a functional thing? You know, the person's just getting lax ligaments. Well, easy way to do it is you observe the medial arch, and we talked about the medial arch in both cases. The patient will stand with both feet on the ground, shoes and socks off. And if they have tight socks, you can probably tell. But stands with both feet on the ground. Then they also stand with just toes on the ground. They stand on their tippy toes for a minute. They lean over and hold a bench or something so they can stand there for a second. And then the other one, the patient sits on the table. The 3 different things you'll be looking at, 3 different positions, and you'll be doing it from behind normally. Functional is if the medial arch is restored. So say if it's flat, and then when they stand, if the medial arch is restored when either patient is standing on toes or seated, is an indication of weak muscles or ligaments. So in other words, if they're standing up and you're looking behind them and they have a fallen arch, if they sit down and take their weight off and the arch springs back to life, or if they go up on their toes and it springs back to life, but then they stand up again and the weight just collapses the arch, then that is a functional. That's weak muscles or weak ligaments in there. Okay, and it's structural is if it's fallen when they're standing up, and they sit down and take all the weight off, and it's still flat. Okay, so that is the functional. Functional is harder to deal with. You're probably not going to change a lot of those. They will probably need some form of a small arch support on the structural. The functional, you can strengthen the muscles and the ligaments, and you can do towel crunches, and we have some examples of those later. We have some things that you can do. So particularly parents or your therapists that are dealing with kids, always check this in the posture of the kids. Keep an eye on this, okay? And that's one way you can tell if it's a structural or a functional. Injuries of the foot. Obviously, we didn't take x-ray in massage school, but you guys should be able to tell. That's the leg bone. That would be the talus in the calcaneus, and that is not supposed to connect like that, right? So we have a severe anterior dislocation of this. How about an Achilles tendon rupture? We've heard of these things quite often, so we know about what that is, the Achilles tendons. So come on down here. If the Achilles ruptures, you might feel a pop. You might hear a pop or snap or even feel it by immediate sharp pain. I've had a few friends playing tennis, and they've gone to twist just wrong, and boom, they heard a loud pop and nothing. All of a sudden they kind of wonder what was going on. Then a few seconds later, boom, immediate pain, and they couldn't walk. They were falling. They had to be carried off. So I've also had a person just step down, walk out the door, and step off the front step and pop. So you don't know, but that is the Achilles tendon. So I don't know. I haven't seen any literature, but I try to do some yoga every night. I try to stretch these, do calf stretches. That's the best way to stretch them, in my opinion. Do some calf stretching, downward dog yoga with the straight leg in the back. Some of you guys know what I'm talking about on that, and holding it for about 15-20 seconds. Things like that will try to help keep it loose and keep the elasticity, okay? Another ankle injury, and we're going to get into this a little bit more, a little bit of surgery. I think I got some surgery images. Those are my original ones. I wanted to share them with the class as well. The most common direction of sprain is inversion. Even though you have fallen arches, you'd think they would be fallen inward, but just the way the ankle design is, rolling out. It's called the ankle roll. Specifically the ATF, the lateral ligament. It's called the inversion sprain is what it is. And it's a sprained lateral ligament is what happened. Now remember, a strain versus a sprain. There's two different things. A strain, the ST, has to do with the tendons, muscles and tendons. The sprain with a P has to do with the ligaments, and ligaments connect the bones. Okay, they're a lot longer to heal. They have a lot less vascular and blood supply, if any. Okay. Achilles tendonitis, which is overuse inflammation. I find these, and that's why I put it, especially common among the weekend warrior groups. People that go out. I've had some patients with this, and we had to do ultrasound and kinesiotaping afterwards, then muscle fan stripping to get the things moving. Basically, what it was they were in their 40s, and then all of a sudden the softball season came on, and they started going 2 nights a week to softball practice. And they were not used to running and hitting and doing all the other things, and that started causing some Achilles tendonitis. They were getting a lot of pain right down just above that bony ridge where it starts to get soft. That's where the pain was. And controversially, that's where a lot of the tears are. That there is the big junction right in there, the weak spot of it. Okay? So if anything's going to happen, it's going to happen right in that area. Now, the strained tendon, you can have grade 1, which is a stretching, which is minor tear, which normally goes away in a day or two. Ice it and kind of rest it. Massage, you can get right in on that. Grade 2 is a partial tear. You need to stop the activity and wrap it and elevate it. Massage, do more like a effleurage type massage, and then later, after a week or two, try to do some stripping on it to get help with adhesions from forming and stuff. Grade 3, totally ruptured, they need to go surgery. Okay, then they're going to be in a boot for a while. Again, injured Achilles tendon may hurt here, and you can also see possibly some plantar fascia pain. And they think, oh my gosh, I got plantar fasciitis starting. No, it could be in this. So use the old RICE, rest, ice, compression, elevation thing for a while at home. Definitely some kinesiotaping on this. Kinesiotaping works great for Achilles issues, and I got a video thing, a link for some kinesiotaping for you guys at the end of this. Now, what kind of ortho test? If we have one that is a suspected person comes in and they're a long-time client and they went out jogging, they did a 5K out of the blue, and they say, you know, I think I might have ruptured my tendon, you know, or I really did something wrong with it. Could you check it? One of the easiest things to do is have the foot hanging off the table and just do a light squeeze of the calf muscle. It's called the Thompson's test. What should happen is when you squeeze, and now keep in mind, guys, we're not trying to do vice grip here, have them come off the table. We're not trying to cause pain. All we're trying to do is squeeze lightly, which would show, which in a normal person, it would show the foot plantar flexing. It would bring the foot out as you squeeze because you tighten up the tendon and it pulls the foot. If it's ruptured, it ain't going to do nothing. Okay, so you can squeeze and do a pumping thing. Squeeze, let go, squeeze, let go, squeeze, let go. And you should see the foot moving pretty good when you do this. Okay, if they have that, chances are they have not done a ruptured, even though they may have a tear, a minor tear, like a grade 1, like we talked about. That, to be honest, it still hurts like hell. But you want to make sure that they aren't a referral candidate with a grade 3, or they don't have a major partial tear and barely connected. So if they have a lot of pain and you're squeezing this and that thing's barely moving, they may have a pretty good grade 2 tear, which I would refer for a consult. Okay, if you're squeezing and ain't nothing happened and they can't walk, they're on a crutch, and they haven't been fully diagnosed, you need to send them to ortho, okay, because they got a grade 3. So what if they're doing good? Then the best way to do it, if they're just kind of aching and they're trying to get back in the game, is to manually free up the tendon. Work the gastroc, get all that loose, then the hamstring tie-ins where it goes up behind the popliteal fossa here, and then work the plantar fascia, because the fascia is also part of that big tendon sheath that goes around. Work all this, then go in on the area that's aching them a little bit. And you guys know as well as I do, it's a weird feel. It's the second most weirdest, in my opinion, the hitting the funny bone, is when you grab a hold of the Achilles. So don't grab it to pinch it because you can really hurt, but grab it just to anchor. And instead of doing 2 fingers, I like the 1 finger like this. But what I would do is start off with a broad contact down here on the midfoot and work the Achilles laterally back and forth. Slow to medium, slow to moderate type speed back and forth with lotion as you work your way up in a zigzag pattern. Do that about 5-6 times. Then come up here and anchor the calcaneus, because you're going to get this moving when you're doing this. You're going to get a lot of rear foot movement to buffer the lateral motion on this. Then slide your hand up on the calcaneus on the heel and do the same thing. Then you're going to be getting all Achilles. Okay, and you can do that, 5 to 10 times as well whenever you move your hand. And then do some parallel muscle stripping on the side, and then if you still feel some restriction, do it again. But meanwhile, watch the patient, because you may be going too hard. Ask them how it's feeling. Watch for signs of the big muscle that's going to contract first is the glute in the hamstrings is going to contract before any of this will. Okay, if you see this bulging up or doing anything, then you're going a little too fast, or you're going too wide in your stroke, or you're pinching too much. Just calm it down and just ask them, say, that was a little tight, I see, so we're going to back it down a notch. We're going to go from 4th gear down to 3rd gear, and we're going to try that again and just keep going. Then you'll find it when they relax, because you want it relaxed. You don't want contractions. Taping. This is what I was talking about with the kinesio taping. This is what one would look like. You don't have to go all the way up to the top, but a lot of them do. These are some of the pre-cuts. And this here is a really good one that I seen on there. That's the address on there. So go ahead and just write that down. And you can put that right in your browser, this URL right in the browser, and hit go. And it'll take you right to YouTube with that address. And it's about a 8-minute long one where they instruct you on how to flex the foot, how to bend the foot, which tape to put on first, how to do a split tear where you get tension coming backwards. It's pretty good to watch. And this, you can order this through Massage Warehouse. You can order it through Scripps, Hesco. You can even get this type of stuff at, I think I was in CVS. CVS has it. CVS Pharmacy even has the rolls of this now. And it's like $8. It's not much. So you guys take a look at that. Oh, this is for the weak stomachs. This here's our image warning. This is going to be, I believe, the Achilles tendon rupture. So this here's Achilles tendon. This here's the foot hanging off the table. This was the actual rupture. So what they have to do is fillet basically open and strip any frayed fragments off the tendon. This here's a partial rupture that you can see here. So what you have to do is start stitching the things back together. Then basically you stitch it crossways to get a solid thing, and then you stitch these two together. So what happens is the foot can't be anything past a 90 degrees. It has to be in a perfect L, maybe a little bit downward. The heel has to be elevated when they stand to put slack in this until the tissues heal. And you can imagine by doing this, it takes a long time to recover. You weak stomachs can turn back now. We're on the next page. It was totally gross. It was totally gross. You guys would not have wanted to see it. After surgery, normally we're in 6 to 12 weeks. Okay. Again, like I said, at first the castor boot is positioned to keep the foot pointed downward as the tendon heals. We don't want any tightness on that tendon. Okay. Then you have to go in for checkups, and they start ratcheting the foot from being pointed down to a neutral position, and that causes a lot of pain and aggravation all over again. Okay, and then you're going through physical therapy. It's a pretty good ordeal. The other thing too, which sucks, is, and to put it frankly, is this is about 1 inch high. So you got 1 inch high leg with a shorter leg, so you start developing knee pain, hip pain, back pain, then neck pain goes up the kinetic chain. So you really need to look at these people. So if someone comes in and they have a boot on, don't isolate just to the lower here. They're going to have a lot of upper body issues that's going to be because of this posture. We're going to hit some of those. It's a crisscross pattern that you'll see. Now, what about some non-traumatic injuries, or even insidious onset, like some of these things here, the bunions, metatarsalgia, neuroma, hammer toes, all those. Let's look at those a little bit. Plantar fasciitis. We had almost a full clinic based on plantar fasciitis. We had a treatment protocol that really, really worked. Let me see. Yeah, I got in here a little bit. Basically, what it is the deep tendon and the fascia comes on down, which is the Achilles tendon, and then it anchors here. Then some fray actually go on around and connect to the plantar fasciitis, to the plantar fascia. Now, what happens is there's supposed to be, you guys know this, the muscles are up through here, the skin and everything else. Supposed to be some movement through here where it can stretch and elongate and then rebound back and then slide along the muscles. Well, sometimes that doesn't happen, and they can get caught, or fibrous adhesions. You can even tear it jumping off things or repetitive things. You can actually start micro fraying this. Then that's when people start getting the pain right in front of the heel. Now, I know some of you guys are saying, well, what about a heel spur? Isn't the heel spur the fasciitis? No. If you have this being tight, just picture the fascia, the white, is pulling all the time, and it comes around the heel bone. Well, sometimes when the heel bone grows, what happens if we have an area in the body, if we have an area that is getting excessive pressure or friction from the external environment? Well, it starts forming a callus, starts forming extra bone. So if we have a heel that's getting extra pressure or friction from the environment, from this pulling on it, it's going to start forming a spur going in the direction of the fascia that's pulling it. Okay, so a lot of people think that is the cause of the pain. Initially, it's not. It's actually the inflammation of the plantar fascia and all the tissues here. So I'm going to show you a few slides later, that's what I was checking, how we dealt with it. Okay, and it can start right here. Normally the telltale signs are the people when they first get out of bed. Those first 10-15 steps are just murder. Or in the middle of the night, if they got to go to the bathroom, they hate getting up because it's like, oh, it just really hurts. So you can have the splints and other things, and to try to keep it flexed at night, or extended, excuse me, at nighttime. Causes: unlocked metatarsal joint at push-off phase of gait, causing a stretch to the fascia. Your metatarsal joint, remember, comes on down the leg bones, right? The tib fib connect to the talus, which sits on the calcaneus, right? So we have our metatarsal joint, which is right in front of that. That's supposed to be locked. So whenever you go to do a gait, when you do a toe off, when the push off phase, that's locked and the whole foot acts as a full functioning unit. Well, if it becomes unlocked, then it kind of bends a little bit, but enough, then it relies on the plantar fascia to keep it from bending more. And that will cause it to keep stretching and cause inflamed. Variety of foot types, tight heel cords, meaning the tight gastroc, soleus, all the way down to the cord right in here. Okay, so if this is real tight, that'll be pulling on this. That's what it's talking about. The Achilles. Great toe flexors or fascia, weakness and control of pronation, training errors, or shoes. There's many causes that can cause plantar fasciitis. Some of the ways that we would do this is we would actually take patients laying down, we would flex the toes back like it shows, then we would take our thumb and gently press across the arch here. And what you'll feel is normally there is, bear with me guys, what you're feeling for is these bands. There's normally 5 bands. Sometimes there's 4 depending on how they were made. Bands that you can feel, and they feel like tight guitar strings going across. Well, the involved one will feel like a tight guitar string, and that's the one that you got to work with, the one that feels like a tight guitar string, because that's the big culprit. Now, there may be, in chronic cases, a few of them like that, and you got to work them. So how do we work it? Well, we start off with a general overall loosening of all the joints, just passive motion of all the joints. We don't push right there because that's a tender spot, okay? Then we would go in and start isolating gently. Don't dig your thumbnail in. Find which one's tight. Then what we would do is you would actually flex the toes down. And meanwhile, say this one right here is the tight one, right in the middle of the foot. You'd flex the toes down because that would put slack in it, right? And then we would anchor it. We would go in about 1/3 and down 2/3 to anchor it against the calcaneus. Identify the tight string, just like it shows here. Thumb on it and thumb on it. Tight string in the middle. We would flex, even though the toes, it doesn't show flexed. We would flex the toes, and that would put slack in the string. We would go in about 1/3 pressure, inward, and then downward toward the calcaneal, the heel bone, 2/3 pressure, and we would anchor it against the calcaneus. Then this thumb would anchor it right behind, because you got your metatarsal heads. It would go in and anchor it and just hold it. And then you got the proximal and distal end of the tight one that has slack in it, correct? Then what we would slowly do is we got it anchored. We don't move our thumbs, but we slowly open up the toe and we extend the toes. We open up the foot, excuse me, and we extend the toes. We stretch it back out while we hold and we grip tight this. Basically, we're stretching that one out passively for the client. If you do it right, they don't feel any pain at all. All they feel is pressure of you anchoring it. Then you can work it throughout the whole thing and do 2 or 3 more times like this. Anchor it, flex it, anchor it, and stretch it. Flex it, anchor it, and stretch it. Then we would do a cross friction massage, would be step 2, across the whole plantar fascia. If need be, we would do this again, is what we would do. Okay? Then once we did that, we would go up and we'd start freeing the Achilles and everything else like we showed earlier, and you can do it sitting up or laying down is what we would do. That would be the 1, 2, 3, 4 method of how we would do it. During home use, we would tell them, hey, get a plastic bottle. Years ago, we used to tell them, get a Coke bottle, because the old glass ones had those ridges on them. We would tell them, drink the Coke, put water in it, and freeze it, and then roll it. But the problem was it became a liability because people were standing on it or the bottle was breaking. And it's like, okay, someone's going to get injured and we're going to get sued. So we found if they did a plastic bottle, and sometimes the plastic Gatorades have those ridges in there, fill it with ice, fill it with water and freeze it and roll it back and forth. That really helps. They can also start then, once they're used to that, on a tennis ball. A lot of people go right to the golf ball. That's too small of a point too soon. Try this and this for the first week, and you can alternate if you have to. Do the tennis ball first, and then ice it down afterwards if you're really sore. If you're not really sore, you can go right to the ice and the tennis ball. Depends on the conditions. Then after a week and you're doing good, then go ahead and do the golf ball, which is more harder, obviously, and more pointed. You're going to get more direct contact. Okay? Then you can keep doing this loop for a while if you want. Sometimes people will do this once a week, to be honest with you, just forever and a day. They'll just keep doing this, and it really helps. Doesn't matter as long as it's helping and solving the problem, right? Now, bunions, hallux valgus. The hallux, which is the big toe, valgus is going inward. So hallux valgus, this is a bunion. We also have hammer toes. That's another one here. Let's talk a little bit about a hammer toe. Most common cause of hammer toe is wearing shoes that do not fit. Tight-fitting shoes as well as shoes that have a boxed-in toe area. Bad deal, okay? Can lead to the condition. Women who wear high heels on a daily basis may be more prone to hammer toe because the high heels put pressure on the toes. Meaning, if you elevate this up, the foot's going to slide anterior as you walk more, right? Because it's higher in the back, it's going to slope downward, putting a lot more pressure on the toes, okay? So what you start seeing then is the toe will come up, and you start forming the calluses all across the top of the toes, okay? These toes are having it because they're longer, they're more prominent in this individual than the big toe is, and they're getting wedged up. She may have nice, pretty shoes, but they aren't doing this person any good. And eventually what's going to happen, if she keeps wearing them, is she's going to get little ulcers on the top, little scabs, and these are going to start getting really aggravated and angry, okay? That's what a hammer toe is. Some tapes. You can start stretching them out and strengthening the tendons by a towel roll. Picking up marbles, dropping in a cup. Now, if you have a fallen medial arch, this is another thing. Remember I said I was going to mention it later? You can have them do because you're working all the muscles under here. Okay? Towel rolls coming up, scrunch it up, then picking them up and putting them in. Okay? This is all good too. So again, you have a hammer toe, try taping it just like it shows here. Okay? Now sometimes to keep them from bunching up, now this here, let me put another thing in. If you have one and you don't change your shoes, no matter what you do, is going to keep, it's going to be there. It's going to keep aggravating. It's just going to get worse. If you've developed one or two hammer toes and you get rid of the shoes that were causing it, but now the tendons are so tight they're actually like this all the time now, then you need something underneath to flatten them out, and you need this to put them together, which is what the tape is. This is actually a hammer toe pad with these built on it. You slide the toes in. It's like a brace that keeps them open instead of bending under. Okay? So you may have to even go to more extremes like this. Normally the CVS pharmacies and things like that will have these things in the foot section. Maybe even Walmart, I don't know. But check out the pharmacy. They should have those. How about a hammer toe, mallet toe, and claw toe? Normal toe, hammer toe is when the ball of the foot starts hitting. This is where our sesamoid bones are, and you start getting a protuberance up on the big joint up on top of the toe, almost like a callus forming. Okay? Well, it is. It is a callus forming on a hammer toe. That's what that is. Again, that's where that splint comes in. Now, the mallet toe it doesn't form a callus on top, and you don't go up like this, but what happens is just the tip of it goes down. Like if you take your finger and you're tapping on the table with the tip of your finger, okay? That's going to be a mallet toe, just like this. Okay? You can still get a little bit of bump, but it's normally in the front, not more so in the back. Now, the claw toe is when you get a protuberance down here at the base, like the hammer toe, and you also get a protuberance up here like the mallet toe. That's called the claw toe. All of them, just like these things show too, all of them is the culprit is shoes. Unless they were born that way, The culprit is shoes. What about bunions? Both medial, which is the first, and the lateral, which is a regular hallux valgus bunion and a Taylor's bunion, um, can be very troublesome, obviously, in some individuals, and it's very prevalent, to be honest with you. Now, what happens is, no coincidence, 90% of bunions are with you women, and some of you cross-dressing men that have to wear the high heels on Saturday nights. The women, when they wear them all the time and shoot to work and stuff, okay, they're a mechanical nightmare for your feet. Overpronation, which is, as you guys should have known, fallen medial arch, flat foot, pes planus, is the driving factor for resulting muscular imbalance that causes the bunion formation, okay? So what happens is the foot will fall and it'll start putting pressure on this joint, and when you do the toe off, instead of going normal, it pushes the big toe inward because of the fallen arch. This here is some of the trigger points that you'll be finding with the bunions, all through these muscles right in here, okay? That's where you'll be finding. Some of them can actually flare upward, okay? Restoring the joint muscle. If you have one with a bunion, here's some bunions. I'll get into those in a minute. If it's, depending on the stage it's in, if it's not calcified already, you can start freeing these up, but you got to strip the muscles first. I would advise doing muscle stripping and working the muscles to get these guys all relaxed first. Then start doing gentle traction of the joint, holding it for about 10 seconds, then back. If they're doing all right with that, then do a light, very minimal distant shearing force up and down, and really watching the client's face, okay? That's what you want to do. Then you can get a little bit more aggressive with the shearing as you get going. Very little, a little bit more. And if you feel grinding and it's bothering the patient, don't worry about it. Don't do that part, okay? So, but again, all these have to be worked first. And can you actually start reducing the bunion? Yeah, you actually can if it's within its limitations of matter, that it's not all calcified in here. Some of the bunions. So this here would be where it starts. This is the first stage. You can see it. Second stage. This is the third stage. You're probably not. You're not going to be doing a lot with these because you got some major joint stuff going on. Okay. You can try to reduce the medial spline of the big toe by putting wedges in here, but it may cause problem because this here is a whole lot of calcification stuff going on in here. These two, you can start reducing these. Okay. Here's what I mean by the treatment options. You can actually do something to start lifting the arch. You can put in some of the spacers. You can actually tighten this as it goes around, pull this, and it pulls the toe out. Again, you can put like I don't polish my nails, but I've seen my wife with the spacers. You can put those in. And this is kind of the same thing, but not as good in my opinion as this, because you can really ratchet this thing and get some lateral pulling on this. Problem is, if that joint is starting to freeze up, you got to be careful not to inflame it, okay? So would I do this coupled with the arch? If they have a fallen arch, that was the problem. Yes. If it was the problem of just wearing high heels all these years and they still had a good arch, then I wouldn't do an arch. I would just do this and start working it, and I would actually have them come in and do this quite often. And I would instruct them to do this on their own in between visits while wearing this. And yeah, over a course of a few weeks, you can actually reduce them. We've done them in our clinic. Oh, image warning. Why do you want to reduce them and try to do this? Because you have a bunionectomy. I've scrubbed in. I was going to be a podiatrist, foot and ankle reconstruct surgeon. I was in school for that, to be honest with you. And I've scrubbed in on quite a few bunionectomies. And this is basically what happens. Is they come on in and they open it and they cut this part right out because it's going out. So they just cut it off level. They sever the ligaments and they move the toe back around. Okay, cut the ligament, straighten it out is what they do. Sometimes they have to put pins and plates and everything else in here. So this is basically the cutter. It just drives right down and cuts off part of the bone. don't think for a second there's not a lot of recovery time and pain involved with this. There is. You don't want to do this unless you absolutely have to. All right, you weak stomachs can look back. What about the compartment center? We've heard of this. Can we help people with this as massage therapists? Absolutely. We've gone over how we can help some of the common foot conditions. Compartment syndrome is also something very, very, could be very severe. You can actually have some death of the tissue, necrosis of this. People can actually lose sensation in their feet because of this. Basically, it's a fascia does not give adequately. It causes a pressure inside the cavity. We have some cavities in our leg, and I'm going to show you these in a second. If the pressure builds up, like when you're jogging long distances or the fascia isn't stretched and we're putting too much of a load on it and we're running, we can develop compartment syndrome over time. And the pressure will compress the blood vessels. You can't get good oxygen in and out. Then you can start get tissue dying, necrosis. And then you can also start getting nerve problems. So there's a lot of things that can happen. And it's a surgical thing to go through with this. And they actually strip it and fillet it open, to be honest with you. But there are 4 compartments in the legs right through here. This is the top of the leg cut in half looking down. So this here is the anterior compartment. This here would be our shin bone right in front, the tibula and fibula. This here would be our soleus right through here. Then the 2 in the back would be our gastroc, our calf muscles. This is our calf complex right here. So this is where your vein, artery, and nerve is going right through here. This here would be probably, I'm guessing, our anterior tibialis muscle, which would be one of the big ones. If this fascia in front doesn't allow for expansion, contraction, or if we overload it with repetitive stress situations too quickly before the body can adapt, you can get a lot of fluid in here, packing it in a tight package that isn't going anyplace, and you get a lot of pressure in here, which can damage the tissue. So again, this here is the compartment. Compartment center. What's the difference between that and shin splint? Compartment center usually produce pain with palpation only if the compartmental pressure is elevated, such as right after the activity. So if we have the anterior compartment, this here is our calf, this here is our front, our shin, this here is the anterior tibialis muscle. If they just got done running the 5K race and they're aching, burning, and they're really hurting, and we took a light, gentle squeeze and they really hurt and went through the roof, then they got a lot of extra pressure because the squeeze is going to put more pressure. And then even after they calmed down a little bit, we did a squeeze and it still hurt, then they probably got some form of anterior compartment syndrome. They need to watch it. We need to do muscle stripping after it's calmed down a little bit where there's no pain. We can get in there and work it. Shin splints will be there long after, 3-4 days later after the activity stopped. They can still do this. And they also produce pain with stretching and manual resistance, like resisted dorsiflexion, like if the foot is hanging down and you put your hand on top and you tell them to raise your big toe toward the ceiling and you resist it. That causes pain, not so much pressure, but that would cause pain. Then you're looking at more shin splints rather than compartment syndromes. Okay? Personal approach, we try to do the stretching, the posterior and anterior. We stretch it. We tape them after we do our muscle working. We do the regular muscle after the symptoms disappear and the swelling's gone. Then we can do the manual massage, work the whole foot all the way up to the knee, all the corresponding, the agonist, and then in the back, the antagonist, make sure everything's moving good. Then afterwards, if we need to, we can ice it. And then again, the K-tape. That does really good. And I don't know if I don't have a link on that, but you can put kinesio tape for anterior tibialis or shin splints kinesio tape. They may have one for anterior compartment syndrome even if you type it. And they'll show you how to do that. So just watch out for the guys with the big hairy legs. Women might like it because it gets them waxed, so to speak. Metatarsalgia. This is the inflammation of the heads, the metatarsal heads, caused by uneven loading on the forefoot during propulsion, during toe-off, during the gait cycle. Okay? Normally the small muscles that run between the bones contract during the final phase of each step, which is toe-off. to prevent the forefoot from splaying and the toes from curling. If these small muscles don't do their job, the foot spreads, I should put excessively, and the toes curl, which causes the metatarsal heads to be forced downward. When your toes curl, they're like clawing, like a claw foot. They curl downward to grip. That drops your met heads down. These are the met heads right here. They will be down on the ground taking the brunt of the force. Then they can get inflamed. Okay, that's called metatarsalgia. Algia is pain in the metatarsal hedge. You can also get metatarsitis. Okay, that's what it feels like. So whenever you take a step, if they're inflamed, you can start getting pain. It feels like you're stepping. It's called the pebble syndrome. Now you can also get some swelling, or you get excessive callus formation under these. You don't have to imagine the type of pressure that's going right on that met head right there and the abnormalities that that's going to be causing. Oh, but she looks cool, but geez, this is a nightmare here. Okay, I used to think women with these were like, because they always had the calf muscles and it made their, gosh, I'm on the air here and I'm married for 30 years, but it made their butt look really nice and firm whenever they wore shoes like this. But now I've become a physician and study biomechanics. This totally doesn't do anything for me now, because I just know, I'm like, oh, lady, they look nice, but you're a wreck. You got to get out of those. Are you that dumb? So it totally changed my outlook on these things. So, but yeah, you can definitely cause some major trouble by wearing these. Especially this. Look at this, guys. There's no padding under here. There's nothing. So, anyways, off my soapbox. Treatment for this: try to splay it across, go in about a third and outward about 2/3. Okay. You can also dig in and try to free up, because some of those inner digit muscles that go across will be overstrained and tight. Okay. So try to hold those and do like releases on those, like a hook, like reflexology, like hooking, and work your way down over these heads. If it's too sore, you may just have to work and gently spread and work and try to do something. Do a sugar scrub or foot scrub, salt scrub for the calluses. And then if it's really bad, where they got the heads are actually forming major calluses, like all in here, and they're painful and red, then you can even have them go to the pharmacy and get some of these pads, metatarsal pads. Now, they won't be able to wear those shoes with them. They'll probably have to wear slippers or extra big shoe, or undo the laces a little bit where they can put it around like this. What about the Morton's neuroma, which is an intermetatarsal neuroma, which is the nerve bundle that inflames? I've seen a lot of these from people in Texas. When we had a practice in Texas, the cowboy boots with the pointed toes. We get these. These are with the shearing forces between the metatarsals, aggravated by the narrow shoes and forefoot imbalance. Okay, right through here. By the narrow shoes or narrow cowboy boots that are a point, it pushes these toes together. And when you're walking, these can kind of shear against these nerves, and it can grind against them where they will inflame and swell. That's your Morton's neuroma, especially with the ganglion right here. I've scrubbed in on probably a dozen of these, where the podiatrist actually go in the top of the foot, make an incision, and pop this bulb out and cut both of those off and take the bulb out and stitch it back up. Now, person loses feeling in these two toes, but the pain is gone. You know, you don't have to do that unless it's called a neurectomy. Morton's neuroma neurectomy. You're cutting the neuroma out. An easy test is the Morton's neuroma sign is push them together, not fast, but just put some nice even pressure. Make sure the foot don't fold up or fold down, that it's right together in line, the toes are in line. And you're mimicking what the shoe does, and it will cause a, if it's a positive, is if you hear sometimes a clicking, meaning the bulb will click in and out, it'll move, you can hear a little popping along with pain. Or you can just get extreme pain and it shoots it up. Okay, that's a positive test for Morton's neuroma. For massage, we really don't do a lot for that, other than if a person's complaining of that, and whenever we try to massage the feet, we're having this issue. Easy check is to ask them, number one, if they wear pointed-toed shoes all the time. or if you do this test, the Morton's aroma test, and push them together if it causes a lot of pain. That's another one. And that was it. That was the conclusion of our foot and ankle course, which I think there's a lot of different things in here that some of you guys probably even have. After I first did this course in 14, I got about 20 emails from the people that took it, having, you described my condition to a T. Now I know what to do. Makes sense, and blah, 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 blah. So some of you may have some of these conditions or know people that do. So anyways, I hope you guys enjoyed. I will conclude this, and I'll be yelling at you with another webinar coming your way. Take care, guys. Dr. Holly, out.